Following Nick Rourke is always a bit of a difficult thing to do, as you can imagine, and I have no videos, no cool videos, especially to show you. I thank the both associations for inviting me to try and answer the question as to what we should learn from a minimally invasive pancreatic registry. To do this, I propose to deal with three issues. The first is to look at how we go about to evaluate new technology. The second is to highlight what a randomized trial teaches us versus what a registry teaches us, and then basically to go through some of the knowledge gaps in minimally invasive pancreatic resection literature to see what should we try to get from a registry. Throughout all this, I have a plea. There are registries being set up at the EHPBA and at the IHPBA, and I'll get back to it in the last slides. Please, please, please start considering entering your patients into those registries. That's going to be the key to our future. I have no disclosures. In the 60s, and some people may not remember this, but the experience of giving thalidomide to pregnant women led to absolute disaster. Because of this, there was a true revolution in the way that we introduce medications. It's a very strict, orderly approach with different phases, and the medication has to prove that it's got efficacy and safety at each of these phases, or it won't go forward. That's not the way we go about with new technology, and perhaps that's a good thing. What it looks like is something like this, a paper from JAMA, where each line represents a different type of laparoscopic procedure which has been introduced. On the x-axis you have time, on the y-axis you have penetration in the community. And what you can see is different procedures have different patterns of going in, and it's a little bit hodgepodge. In fact, it's very haphazard. In order to try and make heads or tails of this, a few years ago, we got groups together in Oxford and came up with a paradigm called the ideal stages of systematic evaluation of new technology. David Kuby went over this a little bit earlier. And what we did is we tried to basically set up different stages, going from the idea stage at the stage 1 all the way to the long-term stage at stage 4. Perhaps what was new from what we did was to try to add methodology, which we thought was the best way to evaluate the technology at the given stage that it's at. So for example, if you're in between stage 2B or 3, that's where you should do a randomized trial. If you try to do a randomized trial before that, it's very difficult because the technology hasn't become refined or stable yet. If you do it after, it's too late. The cat's out of the bag. You'll never be able to recruit patients. When we proposed this paradigm, we thought that registries really came in the long-term phase of stage 4. And I would challenge that now. The registries, I think, have a broader role, and I'll get back to that in a couple of minutes. Now, how are we doing in MIPR, minimally invasive pancreatic resection, with respect to randomized trials? We're actually not doing too badly, and I apologize, the Barcelona trial isn't in here, but there are now 3 trials that have been completed, and several other trials that are actively recruiting, and that's pretty good. The problem, and it's this from a methodological perspective, unfortunately, these are small randomized trials. Most trials in surgery are what we call small randomized trials, and that's especially true in hepatobiliary. What do we mean by small? You've got less than several hundred patients, but that's the best that we can do. The problem is, from a methodological perspective, these are trials that are not convincing. The reason being that it only takes a few events in either group to change your conclusion when a trial has so few patients in it. The other issue is that small randomized trials are not powered for all the outcomes that we're interested in. We're not just interested in efficacy, say length of stay, we're also interested in complications, healthcare utilization, quality of life, and that requires even more patients of what is already a small trial. Finally, and I think this is probably one of the worst problems with the small trials as for surgeons, is that they do not reflect in any way real life, because there's no mix of patients, there's no mix of surgeons, and there's no mix of context where you're applying it. So they have their limitations. I think several organizations have started to realize this, and there's been a broader call for registries earlier and earlier. And there are some groups who used to swear only by randomized trials, large randomized trials, who actually are starting to be convinced that registries are possibly the way to go. And I think right now the knowledge is such that registry data is accepted as being able to serve as a valuable alternative to randomized trials when they're not feasible, or if their conclusions may be of a limited scientific use. The way I look at it, actually, is that randomized trials and registries should be considered as complementary in the information that they bring. There is no way to get a better design than a randomized trial to go and prove efficacy, because it controls both for known variables and unknown variables. There's no other design that does that. But it also doesn't give us the information on a lot of other things that we're interested in, and these happen to be things that are strengths of registries, such as benefits, harm, clinical practice, long-term results, and rare outcomes. Another issue is, what do you do with the conclusions of the hard work that you've put in, whether it's in a randomized trial, meta-analysis, or registry? I've chosen this paper by Isabelle Boutron's group in Paris, where they showed that once a randomized trial is published, you got a whole slew of publications and people quoting it and so on. But as the dust settles and you go years out, in actual fact, data from registries becomes more and more important, possibly because it's better able to convince people of what they should be doing in their practice than the original randomized trial, which was in an ideal world in an ideal population. So that's the importance, I think, of registries. And with that as background, the question is, what knowledge gaps should we address with a multinational minimally invasive pancreatic resection registry? Because of the very short amount of time that I have left, I've chosen three sources of information, which are 3 articles. I've chosen them because they have large numbers, what I consider to be stronger methodologies, and 2 of them use propensity analyses. 2 of them are from the EMIPS group, which is well represented in this room, and one is using the database from the NISQIP collaborative. The first paper, therefore, is a paper looking at Whipple's, minimally invasive versus open, and short-term outcomes. It was from the EMIPS group. It's a retrospective propensity score-matched analysis. There was an asymmetrical distribution of centers that contributed the patients. 14 centers contributed the minimally invasive patients, but 53 contributed the open patients. There was a phenomenal number of patients to choose from, 4,000, which is really unusual to see, and the primary outcome was 30-day major morbidity. I don't have time to go through all of the outcomes and endpoints, but I'll go through highlighted ones. After matching, they were able to get 730 patients in each group, and to show that the postoperative morbidity was similar in both groups. However, the grade B and C pancreatic fistula rate was greater in the minimally invasive group. And what was interesting is before propensity matching, the difference in length of stay was 1.5 days. But after propensity matching, you're down to only a half day as benefit for the minimally invasive procedure as pertains to length of stay, probably related in part to the pancreatic fistulas. What's more is these results are achieved in not the same patients. It was clear that the minimally invasive patients, as you would expect, had no arterial involvement, no vascular involvement, smaller tumors, and low risk of pancreatic postoperative fistula. So the conclusions from the authors for this were that the high rates of postoperative pancreatic fistula seen in the MIS group, and the conversion, and the lack of superior outcomes could indicate that more experience and higher annual MIPD volumes are needed. But the question is still out. Perhaps more importantly, and as Steve Stradford said before, heterogeneity is the enemy of observational studies. And what it means, there's so much going on that it's really difficult to get a conclusion. And we're talking about having had 4,000 patients, but they weren't in a registry. They were in a number of different databases and only partially a registry. The second paper I chose is also from the EMICS group, and it looks at pancreatic tail resection for patients who had body and tail pancreas cancer, and the main emphasis was on oncological outcomes, again, minimally invasive versus open procedures. It was a pan-European retrospective cohort propensity matched study. And in the study, they put a lot of different databases together and made a huge effort to get a good compliance and homogeneity of the data, but to create something akin, as I understood it, to a super database. And the main outcomes were R0 resection, lymph node retrieval, and survival. And this is what they got. Again, I point your attention to the last 2 columns, which are the propensity matched groups. So you end up with 340 in each group from the over 1,200 patients. Length of stay was shorter and minimally invasive by about 1 day. The survival curves in the open and minimally invasive are virtually superimposable, so no difference in outcome there. And the R0 resection rate was significantly greater in the laparoscopic group. But the problem is most of the other oncological technical outcomes, such as performance of splenectomy, resection gerotis fascia, vascular resection, and lymph nodes retrieved, all favor the open group. And in fact, this is probably worse if you want to look at it that way, because the open group clearly had patients that had more advanced disease owing to a greater lymph node staging, greater percentage of lymphovascular invasion, and a greater percentage of perineural invasion. So this is a very well done trial, but difficult to conclude from it. In fact, the conclusion was oncological efficacy is not clearly established, and I believe now the group's gone on to a randomized trial in order to look at that. Again, I would put it to you that if there had been a registry from the start, a lot of the heterogeneity might have been addressed, and perhaps we'd be able to conclude more from it. The last study I show you is not from EMIPS, and it's a group that was seeking to compare the efficacy of a robotic approach compared to open and laparoscopic techniques as pertains to distal pancreatectomy. And they used the 2014 American College of Surgeons NSQIP database. Now, the NSQIP database is a lot closer to a registry than multiple databases because the nurses who record all the events in each of the institutions are trained in the same place and are used to entering all the information in the same way. They had 1,815 patients divided into open, laparoscopic, and robotic. The groups were similar as pertains to comorbid factors, and about half the patients were operated on for cancer. And I'm not going to show you the outcomes because there's no propensity matched analysis on this, so it's not the same as the previously well-done studies you saw. I just want to show you this, which is the characteristics of the patients in each group. And it's very clear that the patients who are having each of the types of procedures are all different patients. They're different in how sick they were before the surgery, they're different in their risk factors for postoperative pancreatic fistula, and they're different as to how advanced the cancers were. So it becomes very difficult to conclude anything. And in fact, the conclusions by the authors were that the outcomes data after risk adjustment bring into question published decreased rates of postoperative morbidity from single center reports using MIPR. So what do I conclude from all this? Well, I think there's limitations, unfortunately, even in large studies that we have, not owing to anyone's fault, just owing to the fact that the patients were entered from different places in different databases. More aggressive tumors clearly, however, often seem to be selected for the open approach. The data are obtained prospectively, but because they're collated only retrospectively later, there's a risk of underreporting a number of complications and especially missing data and rare events. And one other point I wanted to point out is that the body habitus of patients who come from Asia, Europe, and the States are very different. And if you try and put all that in the same database, it becomes more difficult if you don't have the same definitions at every point. So the EMIPS consortium is a fabulous effort that started 2 years ago. I've shown you 2 excellent papers that have come from it, and they are the official sponsor of the EHBBA registry for MIPR, both distal pancreatectomies and pancreaticoduodenectomies. And on their behalf, and I hope I get this right, Mark, I'm inviting all European centers to please contribute to it. The more you get into there, the quicker we'll get to the answer of how to do better for our patients. The start date is expected in January 2019. It's got a strong quality control, such as, for example, random auditing every year of 3 centers. There'll be annual reporting of outcomes, which I hope will be risk adjusted, and it'll be overseen by, I can't think of anyone better to do that than Mo Abu Hilal. I also am putting a plea for you for the IHBBA registry that Dave Kuby started talking to you about. It's a registry that will be very similar and in kinship very close to the EHBBA. Initially, I think the IHBBA would like to start with Whipples, so please to enter your Whipples in the registry to establish a robust prospective database and functioning collaborative network. I hope that they will agree to a plea that I have to put forward, which is not just to include your MIPR patients, but also every open patient that you happen to do at the same period in the same center. Because if not, you're not going to be able to get proper matching. And finally, this will also allow yearly risk-adjusted outcomes for feedback. So I please invite you to join the registries, and if you'll pardon the pun, help make MIPR great again. Thank you.